rampant. It is, especially in our society. Many women, mothers are going through this, and others, unfortunately, they're losing their lives to it. But the information around it may seem vague, and Dr. This particular aspect to us in a more broader manner that we may. Of course, we do have our question of the day. Of course, we like engaging our audience,
yes,
and asking them, to, of course, just have this conversation with us. And we're asking, what measures can hospitals put in place to respond quickly and effectively to postpartum hemorrhage emergencies? What measures can hospitals put in place to respond quickly and effectively to postpartum hemorrhage emergencies? Would love to know your thoughts on the same. Our handles on Facebook and X are at K24 TV, and our WhatsApp line is right there on your screens. Now, Dr. let's demystify this. Let's start by defining, postpartum hemorrhage. And just to mention, we did have this conversation on Friday, but today we're looking at it in a broader sense.
Thank you. Thank you very much for inviting me to the studio to talk about this topic of postpartum hemorrhage. It's sort of a mouthful, postpartum hemorrhage, and people may not understand when you're talking about postpartum hemorrhage. But put it simply, it basically means excessive bleeding after delivery. So when a woman goes to deliver, when a pregnant patient comes to deliver in hospital, if she's going to deliver normally or vaginally, we expect her to lose a little bit of blood, and she may lose about 150 milliliters of blood, which is about 1 glass full.
I see.
Almost. Now, which is acceptable. However, if she loses about 500 milliliters, half a liter of blood during normal vaginal delivery or more, that is what we call excessive bleeding after delivery, the postpartum hemorrhage.
I see.
The mouthful that we are talking about.
Right.
Now, during a cesarean section, where we operate, where we cut the abdomen and go in and get the baby out, we expect such a patient to lose about half a liter of blood. However, if this patient loses more than a liter and more of blood, that is 1,000 milliliters, then we also call this postpartum hemorrhage or excessive bleeding after delivery through a cesarean section. Now, there are many reasons, because normally what happens when a woman is expectant, apart from the baby that a woman is carrying, there is the amniotic fluid which surrounds the baby. Very, very important aspect of for the baby. Why? Because the amniotic fluid acts as a shock absorber for the baby. That is number one. Number two, it's a very good indicator. It tells us what is actually happening with the baby. Because remember, this is the same fluid that the baby swallows, and is the same fluid that the baby, urinates. So the baby actually drinks its own urine. Let's put it that way. But even if that happens, when we do an ultrasound scan, ile picha tunafanya, that amniotic fluid gives us information about the well-being of the baby. If it's a normal amount of amniotic fluid, it means that the digestive system is okay, the swallowing, the intestines are fine, and the urinary system, the kidneys are also functioning. So there is that amniotic fluid. And then apart from that, there is the placenta. And the placenta is the structure that connects the baby to the mother through the cord, what you call the umbilical cord. So when you have a baby of, let's say, 3 kilos, 3.5 kilos, then you have amniotic fluid, which may be about half a liter of fluid. And then you have the placenta, which can be about 500, 700. Sometimes it can be slightly bigger, 750 grams. So in total, you find the whole content of that uterus is about 3 point something or even 4 kilos. Remember, before a woman, it is. And this is where the Bible comes in very, very nicely. In Psalms, I think it's 139, where the psalmist says that we are wonderfully and beautifully created, or something to that effect. What does that mean? Before a woman gets pregnant, the womb is actually like a small structure. just about my hand here, my fist, about 140 grams. And then remember that at 10 months, or as 9 months, as people say, oh, you carried a baby for 9 months, it's usually around 10 months. That structure, which is about 140 grams, will actually expand such that it will carry that baby who is 3.5 kilos, let's say, sometimes twins, sometimes even triplets. And then it will carry the amniotic fluid, and it will also carry the placenta as well. So it expands terribly. And then now, once that woman has delivered, this structure which has expanded terribly over the 9-10 months, it has to do what? It has to contract and go back to the original structure. What actually is the cause? What are the causes of postpartum hemorrhage or excessive bleeding after delivery? You find the womb has expanded, and then when it comes to contraction, it is not contracting the way it should. Now, we talked about the placenta. The placenta actually is connected, structure which lies on the womb, the inside part of the womb, and there are blood vessels that cut through, so that these blood vessels, through these blood vessels, oxygen and nutrients will pass from you, the mother, to the child, through the cord to the baby, and some of the waste products will go the other way as well. Now, when we have an overexpanded uterus, you find that now, when the mechanism for contracting that uterus may not function the way it should. For example, you have a big baby. There's a time I was in KNH, I work in KNH, and during one of the labor ward rounds, we had a patient who, when we asked her her history, it was unbelievable. She had delivered a baby who was 6 kilos naturally. And then she delivered another one who was, I think, 4.7 kilos, another one 4.5 kilos, another one 4.2 kilos.
Those are 4 pregnancies?
Yes.
4 babies?
4 babies, and all of them were more than 4 kilos. So the smallest baby she delivered was 4 kilos, 4.2 kilos. Which in itself is actually something that is scary, because you know the passageway where the baby is going to pass through, when the baby is too big. Normal delivery. They were all normal deliveries, which is mind-blowing, if anything. So if we have a big baby, for example, the uterus expands, and then that mechanism of contraction may not kick in the way it should. So you have the uterus which is over-distended, what we call an atonic uterus. It loses its tone, so the muscles do not contract the way they should.
So it becomes looser, rather.
So it is loose, and the vessels, you remember I talked about the vessels? So the vessels are open because the placenta came out. Because normally what happens, the vessels are between the muscular tissue, and when the placenta comes out, the muscles, you know, close, and it occludes the vessels, so it stops bleeding.
Right.
But when that doesn't happen because it's loose, the vessels will keep on bleeding into the uterus, and that will lead to excessive bleeding. So if you have a big baby, if you have twins, for example, more than one baby, twins, triplets, you know, and so on, it's the same mechanism. It's overstretched. You may have structures, for example, which are growing on the womb, what we call fibroids. Very, very common problem in this part of the world. 30 to 60% of women of African origin, whether they're in Kenya, in Cuba, whatever, so long as they have African origin, they will tend to have more fibroids. The number is more than 1 or 2, and then the sizes are also a lot bigger. So if they are there, it will also hinder the natural mechanism of contraction. So you find instead of the uterus contracting, it is hindered, the muscles contracting, they are hindered because there is a structure there. If you have a large amount of amniotic fluid, that shock absorber that I talked about, you find again the uterus is overextended, and then the
so that's also a risk factor.
It's a risk
having
factor.
A lot of amniotic fluid. And how does that occur? Is it an abnormality?
Most of the time we actually don't know why. But in some of the cases, we find the baby has a problem with the stomach, because now the digestive system is not functioning well. You find what you call a double bubble. When you do a scan, you'll see two two structures instead of one. So you find there is a constriction in the stomach. So you find that even though the baby is swallowing, the fluid does not go all the way. So it tends to accumulate. You may also find that the baby has an issue with the kidneys. There's a problem with the kidneys, so they are not excreting the urine the way it should, so it tends to accumulate.
And that's all from having a lot of amniotic fluid. That's
yes.
Wow.
Okay. Now there are also some other issues. For example, you find that once a woman has delivered, the placenta doesn't come out completely. So bits and pieces of the placenta stay inside, and this will inhibit the contractile mechanism, so she will continue bleeding. Now, you may find that there can be injuries as well in the passage. If you imagine the womb as a balloon, and where we blow into the balloon, we call it the cervix. The cervix has two openings. Here where we'd be blowing into, and where the air goes into the balloon, as it were. So sometimes when a woman delivers, there can be tears on the cervix itself, or sometimes you'll have tears in the womb itself. Say, for example, a woman had a previous cesarean section, and if she has not been taken care of properly, she may come, with bleeding, or there could be a tear where the previous scar was, and so on and so forth.
Right.
Sometimes you have what we call a placenta not in the place where it is supposed to be. What do we mean? What we mean is that this placenta is not supposed to cover the outlet where the baby should be coming out, right. What we call placenta previa. And usually this placenta previa can lead to bleeding even during the pregnancy, and then if it is not sorted out well and not recognized, not diagnosed in advance, and this woman comes to deliver, she's going to have problem. There are vessels as well, what you call vasa previa, where the big vessels are run actually right in front of the opening where the woman is supposed to deliver through. And if this is not recognized, it's going to be a huge challenge.
So you can find a lady delivering, and but she has the restrictions of this organs or vessels, and then if that is not caught, she'll just still deliver, but then still have excessive bleeding.
First of all, she will have a challenge in delivering, because there'll be huge gushes of blood coming out.
Wow. Because
that opening is sort of blocked by the vessels. And then we have what we call placenta accretor spectrum. What does that mean? Normally, the placenta is supposed to lie just on the womb, the inside of the womb. But sometimes you find the vessels that I talked about, they penetrate the muscle of the womb. Sometimes they're just superficial, sometimes they go right into the womb itself, and sometimes they can even go into other structures, for example, into the bladder itself, and this becomes a huge challenge. So if this is not recognized in advance, and you say, okay, we are going to do a cesarean section, for example, but we don't know that there is this problem of placenta accretor spectrum, you end up in big trouble. Because first of all, if it is, for example, it has infiltrated, it has gone into the bladder, when you open what you call the anterior wall of the womb, you find that the placenta is right in front of you, and it's bleeding, and you can't get to the baby. So if you don't know what to do, and you lose your head, because you can lose your head, especially when there's a lot of blood, coming out, and if you don't have a plan B, as we teach our residents, we tell them, when you go to theater, you have to have a plan A, a plan B, and even a plan C. Such that if I go in and I open and I find there is this, what can I do very quickly? Right. Thinking on your feet, as it were. Yeah. And if that doesn't work, you also have to have a plan C. Just like pilots. Pilots say, okay, this is the way we are going to take. In case something happens, I will take route B. And in case that happens, alternative is route C. So that is what we teach our residents. So
and I'm just curious, yes. Doctor, before you continue, cesarean sections have also been noted as one of the biggest risk factors when it comes to excessive bleeding, during or after birth. But you find in the scenario, for example, the guest I had on Friday during the bulletin, she mentioned that she's gone through cesarean section births like 4 times.
Yes.
Actually 3 times, and then the last time the baby died.
Oh dear.
But she was not taken care of the first 3, or even given information as to why she was bleeding so excessively. And the fact that it's a miracle that she's even alive, and she came to know, unfortunately, when the baby died while she was still pregnant, like the baby died while not delivered.
Yes.
So why is it that this information, like we mentioned in the beginning, seems out there, but then it's not? And even doctors, some doctors don't seem to, you know, have information on it, because I mean, this is a case that is very urgent, but she's walking around like it was normal. She also had no knowledge.
I think the issue of advocacy, just general advocacy, when you talk about women issues, women health issues, pregnancy issues, infertility issues, gynecological, oncological issues, we don't have a lot of information out there. As in some other countries, for example, in the UK, or even in the US, or even in most European countries, you'll find that they have a proper website where all this information is simplified, and it is palatable to practically everybody. Of course, they have more resources and so on and so forth, but that is not an excuse, really, because now with the internet and so many other things, I think we are able to actually get this information, put it in small bites whereby anybody can actually can access it and can be able to read it and understand it. And also the other thing is that it may have to be broken down into several languages as well, because you may find that you know, I'm not proficient in the English language. I don't read very well in the Swahili language, for example. So maybe the other thing is to put it in them. Be it as it may, it is not an excuse. But this information, I think personally, from where I sit, we need to do a lot more advocacy. You know, the whole spectrum, the whole continuum of from preconception, you know, during pregnancy, antepartum, during delivery, and post-delivery as well, which is where we come in with the excessive bleeding. The issue of a cesarean section is also quite a controversial issue. Let me start by saying that the numbers have been going up. According to WHO, our numbers should be about 10–15%, but you find that in some places, especially in the referral hospital, in Kenya, or even generally on average. But you find that in some places the cesarean section rates are very high. You may find even up to 60%, and so on. There are different, I think, drivers for this. First of all, especially when you come to referral hospitals, we get all or most of the complicated cases of, you know, preeclampsia, cases of, you know, malformations of the baby, cases of where the patients have serious issues, where there is cardiac issues, you know, and so on and so forth. So the cesarean section rates in referral hospitals is going to be higher. But sometimes you find that in some, and this has been seen before, in a country like Brazil, where a study was done, and they said, you know, some of the doctors there decide we are going to plan and do this on a certain date because it's convenient for me. I have to travel, I have a vacation, so we have to plan and do this. The case of the patient that you had here on Friday, who had the 3 cesarean sections, cesarean section, first of all, is major surgery. I think we have to be very clear about that. It's major surgery. This thing of saying, nilifanyiwa Caesar too, it is not Caesar. We have seen serious issues when it comes to incompetently done cesarean sections. I have gone into the abdomen because these patients have come from different places, and when you go in there, you ask yourself, goodness gracious, who did this?
Right.
Who did this? Because it is all jumbled, and then you find that it's horrible. We've had to remove wombs for patients who are first-timers, went to deliver, and for whatever reason they had a cesarean section done somewhere with incompetent people, and then the complications afterwards are simply out of this world. So it is major surgery. it should be done or even must be done by experienced people. Or if it has to be done by people who are training, then it's under supervision, because the consequences can be horrible. Women lose their lives because of that. And it is actually one of the reasons of postpartum hemorrhage. Some of the reasons, if it is not done well, you'll have serious consequences. About the lady, I'm sorry I didn't know her story properly, but if she lost her baby in the womb, as it were, unfortunately, that is what you call intrauterine fetal demise, IUFD. There are very many reasons for that. And one of the worst things that we experience as doctors is when a mother carries a baby all the way until term, 38 weeks, 40 weeks, she comes to hospital to deliver, the baby is dead. What you call stillbirths. Stillbirths affect about 11% of women in Kenya. Who come to deliver. My colleague, Dr. George Wako, actually did a PhD thesis on stillbirths. It is a big problem. And I think the problem is during what you call the ANC, antepartum, antenatal care, which we go a little bit back and say, you know what, before even a lady decides she wants to get pregnant, she also needs this information. What do you expect? When should you get pregnant?
And you know, that's idealistically what we would want or expect in society.
Our compatriots said, you know, our dreams are valid.
Yes, yes, they are. And you know, just bring me back to, you know, we were having a conversation before we came on the show, and we were just speaking about society in general.
Correct.
You know, we have very many young people due to aspects of culture, you know, social upbringing, you know, like their families and the like. So we're having more young people getting pregnant.
Yes.
And most of it is unexpected.
Which ideally they shouldn't.
Yes, which ideally they shouldn't, right?
They have no business doing this thing. I mean, at 14, 15, 16.
Exactly.
Engaging in sexual activity, I think it's not the right way to go.
So what kind of also complications, because now that you mentioned that about, you know, age is a very big factor. What kind of complications also come and lead to now this factor that we're speaking about, which is the excessive bleeding? Because you're still growing, you know, you're a young lady, you're still growing.
Yes.
You know, unfortunately, here you are with a child, very unexpected. Maybe you didn't even know.
Yes.
You know, and then all of a sudden you are experiencing all these issues, all these problems.
Yes. Unfortunately, we go back to advocacy again.
Yeah.
When you talk about advocacy, it is basically giving information, the right information, the right at the right time, and in a manner that a certain population can actually consume it and use it in a way that will help them. Now, when you talk about teenage pregnancies, for example, which is what we are talking about out there, Kenya has this unenviable position of being one of the countries where we have the highest numbers of teenage pregnancies. During the COVID time, over 200,000 teenagers got pregnant. And these numbers are actually almost the same, around that much. And there are some counties which are sort of have this fame, can put it, bad fame of being, you know, among the top counties where we have teenage pregnancies: Kajiado, Narok, Kilifi, Bungoma, and so on. And there could be different, several drivers, and the drivers are many. Number one, lack of information. They don't have this information in primary school, secondary school. And you would be surprised that even in the tertiary institutions of learning, they also don't know some basic information about how does the female body behave. How does a normal menstrual cycle, what is a normal menstrual cycle? What happens here, what happens there? If you were to have intercourse at this point, what would you expect? Some very basic things. What can we call, you know, a normal flow? When should you get worried, and so on? So there is lack of that information. So when we try to talk about that information, say no, we shouldn't give this information to children because you are over-sexualizing them. It's a different topic altogether. You can invite me here and we'll talk about it. Now, when these young people get pregnant, do they contribute? Are they contributors to the numbers that we have, which are horrible? And the numbers are actually horrible. 355 women die. 355 women die out of every 100,000 women who deliver. So, If 1 million women delivered in a year, we would lose 3,555. Meaning, if we round it off to 3,600, it would mean that in a year we lose 3,600. It would mean that in a month we would lose about how many? 3,600 divided by 12, about 300. It would mean that in a month we would lose about 300. If you divide that by 4, is about how many? 75, 150, yeah, about 75 women in a week. And in a day.
That's alarming. And I just need you to hold on to that thought.
Yeah.
We are going for a short break. We'll be back with more of this conversation. Stay with us.